Hello everyone, let's do some Passmed questions. A 34-year-old female presents with fatigue and frequent headaches. On examination of her eyes, you notice an abnormality during the swinging light test. As the light is moved from the left to the right eye, both pupils appear to dilate. This is RAPD, relative afferent pupillary defect. The pupil response to accommodation is normal bilaterally. Fundoscopy is also normal bilaterally. Her past medical history includes type 1 diabetes and hypertension. What is the most likely explanation for the patient's sign? What usually causes RAPD? Relative afferent pupillary defect. The third nerve is functioning. Second nerve is also functioning, however. I think that's reduced function of the second nerve. It usually happens when the lesion is at the initial part of the optic nerve. I think the one immediately behind the eyes. So what could cause this? Wait. As the light is moved from left to the right eye, both pupils appear to dilate. So the right side is having a problem. Right afferent. Right side is having problem. Argyle Robinson pupil. It's the thing in syphilis, I think, where you respond to accommodate but doesn't respond to light. Marcus Gunn pupil, relative afferent pupillary defect on the right. Yeah, this is the one. Why do they call it Marcus Gunn? Holmes Eddie's pupil, I don't know what's this. Diabetic eye disease. Usually affects the fundus. The retina. Usually affects the retina. Raised intracranial pressure. Usually causes optic disc swelling. No, Marcus Gunn pupil is the answer. Marcus Gunn pupil relative afferent pupillary defect is diagnosed during the swinging light test if there is damage to the afferent pathway, retinal optic nerve, or of one eye. The pupil of the affected eye will normally dilate when the light is shown into it. This is because the consensual pupillary relaxation response from the healthy eye will dominate. Marcus Gunn pupil can be found in patients with multiple sclerosis. Therefore, given the history, this should be ruled out in this patient. The history and examination findings in the question are not typical of raised intracranial pressure. Raised intracranial pressure may present with symptoms such as headache, vomiting, bilateral blurred vision, and seizures. Patients with increased intracranial pressure often have bilateral papilledema on fundoscopy. Although the history states the female is a diabetic, there are typically normal pupillary light responses in patients with diabetic eye disease. Furthermore, with diabetic eye disease, you expect to see some abnormality on fundoscopy. Holmes Eddie's pupil is dilated pupil, which poorly, if at all, reacts to direct light, however slowly reacts to accommodation. This does not correlate to the history. The information given in the question above does not suggest Algar-Robertson pupil. This is characterized by constricted pupil that does not respond to light but responds to accommodation. It's usually bilateral, often associated with neurosyphilis. Let's look at this video here. RAPD.
In this patient, you will see that the right pupil consistently dilates as the light is swung toward it. This dilation is called a relative afferent pupillary defect. It usually signifies that an optic nerve lesion is present on the side of the dilating pupil. This test is the most sensitive and the only objective way to demonstrate a unilateral optic nerve lesion or bilateral but asymmetric optic nerve lesions.
Also known as Marcus Gunn pupil. Relative afferent pupillary defects found by a swinging light test caused by lesion anterior to the optic chiasm, i.e. the optic nerve or retina. Finding the affected and normal eye appears to dilate when light is shown on the pathway of pupillary affects afferent the retina to the optic nerve to the lateral geniculate body to the midbrain. Efferent is Edinger Westphal nucleus of the midbrain to the oculomotor nerve. A 22-year-old man diagnosed with asthma 1 year ago has since been using a salbutamol inhaler when required. He's otherwise well with no significant past medical history. He lives alone in a student accommodation. He does not smoke and drinks about 2 to 3 cans of beer every week. His symptoms were well controlled, but he has recently been using his inhaler more frequently, about 5 times a week. He also reported having night cough, which disrupts his sleep. The GP decides to modify his treatment regimen to better manage the patient's symptoms and improve his quality of life. Which of the following is the most appropriate next step in the management of this patient? So he's 22 years old, diagnosed with asthma 1 year ago. Is he only on salbutamol though? Then add a low dose ICS. Yeah, I don't know why he's not started on it yet. Okay, next question. A 28-year-old builder attends the respiratory clinic for review. He reports a 6-month history of progressive dyspnea and exertion associated with coughing. He has also been started on salbutamol inhaler by his general practitioner, which he's now using several times a day. That's not good. No good control at all. He has been smoking since the age of 18 years and has a 10-pack year history. Additionally, he reports occupational exposure to asbestos. Further investigation with spirometry testing reports FEV1 to FVC ratio of 0.68, FEV1 pre-bronchodilator 3 liter, FEV1 post-bronchodilator therapy 3.4 liter. What's the most appropriate intervention for this patient? Sounds like it is a restrictive disease because it's less than 0.7. I think that's the threshold. Arbitrary threshold, either 0.7 or 0.8, I can't really remember. And then it kind of affected by bronchodilator, but how many percent is this? 3.4. Okay, so bronchodilator reversibility, I think the threshold is about 12%. You need to calculate that. So what is 0.4 over 3? That's about 13%, 13.3%. So it's above 12%. So if the threshold is 12%, you will respond to ICS. Okay, so let's look at the explanation. Adult with asthma not controlled by a SABA at a low dose ICS. Low dose inhaled corticosteroid ICS is the correct answer. The birth history and spirometry are consistent with diagnosis of asthma. FEV1 FVC ratio of less than 0.7 indicates obstructive pathology. An increase of FEV1 from 3.0 to 3.4 liters with bronchodilator therapy indicates reversibility. The criteria for reversibility in the diagnosis of asthma is a more than 12% change in FEV1, which must also be an absolute increase in FEV1 of more than 200 ml. In this case, it's 400 ml. Okay. The reversible obstructive pulmonary pathology in this scenario is consistent with a diagnosis of asthma. The asbestos exposure and smoking history are red herrings. The addition of a low-dose ICS inhaler is the next step in the maintenance treatment of asthma after the failure of short-acting beta-agonist inhaler. Long-acting beta-agonist and long-acting muscarinic antagonist inhaler is an incorrect answer. This would be the next step if the patient has a diagnosis of chronic obstructive pulmonary disease, COPD. And FEV1 and FEV3 ratio of 0.7 is consistent with the obstructive pathology of COPD, and reversibility can also be seen in COPD. However, this patient has a minimal smoking history over a relatively short period of time. Although there is no definite minimum number of pack years for the development of COPD, it is often considered that more than 15 pack years is clinically relevant and/or a smoking history of over 20 years. This would make a diagnosis of COPD less likely than asthma in this scenario. Long-acting beta-agonist LABA inhaler is an incorrect answer. LABA inhalers are typically introduced for the control of asthma symptoms following the failure of a SABA inhaler, low-dose ICS inhaler, and LTRA combined. Omalizumab is an incorrect answer. Omalizumab can be used in the maintenance treatment of asthma. However, it is usually reserved for patients with difficult to control symptoms who have failed various combinations of other maintenance therapies. Omalizumab sounds like a monoclonal antibody, actually. Omalizumab. So, omalizumab, pharmaceutical, particularly therapeutic indication for allergic asthma, chronic rhinosinusitis, urticaria. It's a recombinant DNA-derived humanized monoclonal antibody that selectively binds to human immunoglobulin E, IgE. Binds to IgE. The antibody is IgG1 kappa that contains human framework regions with the complementary determining regions of a murine parent antibody that binds to IgE. Mechanism of action: omalizumab binds to IgE and prevents binding of IgE to Fc, what do you call it? Epsilon Ri, high affinity IgE receptor on basophils and mast cells, thereby reducing the amount of free IgE that is available to trigger the allergic cascade. Treatment of atopic subjects with omalizumab resulted in a marked downregulation of this receptor on basophils. Treatment with Xolair inhibits IgE-mediated inflammation, as evidenced by reduced blood and tissue eosinophils and reduced inflammatory mediators, including IL-4, IL-5, IL-13, by innate, adaptive, and non-immune cells. So binds to IgE. It's an IgG that binds to IgE, reducing the. It binds to IgE receptor on basophils. Green piece. Next question. A 66-year-old woman with a history of chronic kidney disease, stage 4 and metastatic breast cancer, is admitted with a swollen right calf. Investigations confirm a deep vein thrombosis, and she started on treatment dose of dalteparin. As she has a significant degree of renal impairment, it is decided to monitor her response to dalteparin. What is the most appropriate blood test to perform? Dalteparin is heparin, right? So heparin, you monitor via APTT. Is it? Heparin acts by blocking antithrombin 3. Antithrombin 3 works on I don't know. What does antithrombin 3 work on? Can you actually measure antithrombin 3 levels? Ni APTT lah. Answer is anti-factor 10A levels. There are two main types of heparin: unfractionated standard heparin or low molecular weight heparin, LMWH. Heparins generally act by activating antithrombin 3. Unfractionated heparin forms a complex with which inhibits thrombin factors 10A, 9A, 11A, and 12A. 9, 10, 11, 12. Low molecular weight heparin, however, only increases the action of antithrombin 3 on factor 10A. activating antithrombin 3, increased action of antithrombin 3 on factor 10A. But 10A is in a common pathway. But you can measure anti-factor 10A levels. Adverse effects of heparins include bleeding, thrombocytopenia, severe osteoporosis, and increased risk of fractures, and hyperkalemia. This is thought to be caused by inhibition of aldosterone secretion. The table shows differences between heparin and low molecular weight heparin. Standard heparin is intravenous, low molecular heparin is subcutaneous. Standard heparin, short duration of action, low molecular weight heparin, long duration of action. Mechanism of action of standard heparin and activates antithrombin 3 forms a complex that inhibits thrombin factors 10A, 9A, 11A, and 12A. For low molecular weight heparin, activates antithrombin 3 forms a complex that inhibits factor 10A. Side effects: bleeding, heparin-induced thrombocytopenia, and osteoporosis. In low molecular heparin, there's a risk of bleeding, but there is a lower risk of heparin-induced thrombocytopenia and osteoporosis. Monitoring a standard heparin is with APTT. I think APTT is measuring the intrinsic pathway, which includes factor 12, factor 11, factor 9, factor 8. And for low molecular weight heparin or anti-factor 10A, although routine monitoring is not required. So why anti-factor 10A? It's actually antithrombin 3 activates by it. Low molecular weight activates antithrombin 3, right? So antithrombin 3 and low molecular heparin forms a complex that inhibits factor 10A. Okay. Why is anti-factor 10A? Is it the same as the low molecular weight heparin, which binds to antithrombin 3? Notes. Standard heparin is useful in situations where there are high risk of bleeding, as anticoagulation can be terminated rapidly. Also useful in renal failure. And for low molecular weight heparin, now standard in the management of venous thromboembolism treatment and prophylaxis and acute coronary syndromes. Heparin-induced thrombocytopenia, immune-mediated antibodies form against complexes of platelet factor 4, PF4, and heparin. These antibodies bind to the PF4 heparin complexes of the platelet surface and induce platelet activation by cross-linking Fc gamma 2A receptors. Usually, this does not develop until 5 to 10 days of treatment. Despite being associated with low platelets, HIT is actually a pro-thrombotic condition. Features include a greater than 50% reduction in platelets, thrombosis, and skin allergy. Address need for ongoing anticoagulation, direct thrombin inhibitor argatroban, danaparoid. Heparin overdose may be reversed by protamine sulfate, although this only partially reverses the effect of low molecular heparin. Overdose may be reversed by protamine sulfate. Let's look at the video on heparin-induced thrombocytopenia. I can remember, for goodness sake.
Learning medicine is hard work. Study plan more. Try it free today.
The term heparin-induced thrombocytopenia can be divided into two parts. Heparin refers to an anticoagulant medication which prevents blood clots from forming, and thrombocytopenia refers to decreased number of thrombocytes or platelets in the blood. So, heparin-induced thrombocytopenia, or HIT, is a complication caused by heparin that results in decreased platelets in the blood. Okay, so imagine you're making dinner and accidentally cut one of your fingers. Now, if your body doesn't stop the bleeding, you'll keep losing blood until there's not enough to supply the vital organs like the heart and brain. Now, to prevent this from happening, the body has a process called hemostasis. This process has two phases: primary and secondary hemostasis. In primary hemostasis, platelets aggregate to form a plug at the site of an injured blood vessel. While these platelets are aggregating, coagulation or secondary hemostasis starts. This is where numerous enzymes that are always floating around in the blood, called clotting factors, get proteolytically activated, meaning that activation happens when a small piece is chopped off, a bit like pulling the pin out of a grenade. These factors activate one another, eventually leading to the activation of fibrin, or factor 1A. That results in a fibrin mesh, which forms around the platelet plug to reinforce it and hold it together. Without primary and secondary hemostasis, our body would suffer massive blood loss from even the most minor injuries. Imagine losing all your blood from something as simple as a pinprick. Okay, so heparin-induced thrombocytopenia is caused by heparin. This medication works by activating an enzyme called antithrombin 3, which inhibits coagulation factors 10A as well as thrombin. This halts secondary hemostasis and prevents existing blood clots from growing larger. So it's often given to people who suffer from pulmonary embolisms, strokes, and myocardial infarctions. Now, the main mechanism behind the development of HIT is actually an immune response, which starts when heparin binds to a protein on the surface of inactivated platelets called platelet factor 4, or PF4. Together, they form a complex called the heparin PF4 complex. This complex is immunogenic in certain people, meaning they have circulating IgG antibodies that recognize the complex as foreign pathogens. So, these antibodies will bind to the heparin PF4 complex and mark it for destruction within the spleen. Now, when the antibody binds, it causes the platelet to activate. The activated platelets release procoagulant chemicals like thromboxane A2, or TXA2, which causes other platelets to activate. At the same time, the original platelet will also release more PF4s, so more antibodies will bind and keep it activated. These events lead to more and more platelets getting activated, and they start chemicals like thromboxane A2, or TXA2, which causes other platelets to activate. At the same time, the original platelet will also release more PF4s, so more antibodies will bind and keep it activated. These events lead to more and more platelets getting activated, and they start forming clots throughout the body. This way, a lot of the remaining platelets also get consumed, which results in a low platelet count. It generally takes a week for the body to make IgG antibodies that target the heparin PF4 complex. Thus, thrombocytopenia typically develops 1 or 2 weeks after starting heparin therapy. The exception is that if heparin is given to someone who was already treated with heparin previously, they would already have the antibodies against the complex, so thrombocytopenia may develop within a day. Now, the widespread formation of abnormal clots can lead to life-threatening thrombotic events, which are most often venous, causing deep vein thrombosis. Sometimes, this thrombus can break down, and part of the thrombus, also known as emboli, can lodge into the pulmonary circulation, leading to pulmonary embolism, which is often life-threatening. Thrombus can also develop in cerebral veins, leading to cerebral venous sinus thrombosis. Compared to the venous thrombosis, arterial thrombosis is less frequent. Arterial thrombosis can block the arteries supplying limbs, causing limb gangrene, or brain, causing stroke, or heart, causing myocardial infarction. Now, the diagnosis of HIT is often made clinically along with the help of some laboratory tests. For example, individuals who recently started heparin therapy and experience a decrease in platelet count either within 1 to 2 weeks or within a day suggests HIT. The level of platelets can be found by using a complete blood count, or CBC. Other diagnostic tests include an ELISA serological assay to detect the IgG antibodies. However, many individuals that have received heparin previously will have these antibodies, but not all of them will develop HIT, so the test is not very specific. A more specific test is a serotonin release assay, which is the gold standard for diagnosing HIT. In the serotonin release assay, the patient's serum is mixed with heparin and donor platelets. Activated platelets release serotonin. So in a positive test, the patient's serum has antibodies that activate the platelets and the serotonin level will increase. While confirming the diagnosis, it's important to immediately stop giving the patient heparin and to start anticoagulation with a non-heparin anticoagulant, like argatroban, which is a thrombin inhibitor. If the patient has a thrombotic event, anticoagulation is continued for 3 to 6 months. If there was no thrombotic event, then anticoagulation continues until the platelet count normalizes. Alright, as a quick recap. Heparin-induced thrombocytopenia, or HIT, is a condition where individuals on heparin therapy develop thrombocytopenia, or a low platelet count in the blood. HIT occurs as a result of an immune response, which ultimately causes the platelets to get activated and used up during the formation of abnormal clots. These clots can block veins and arteries, leading to life-threatening thrombotic events like deep vein thrombosis, pulmonary embolism, cerebral venous sinus thrombosis, and less commonly, limb gangrene, stroke, or myocardial infarction.
Thanks for watching.
With HIT. Let's enter anti-factor 10A. Anti-10A assay, heparin assay. The anti-factor 10A assay is a functional assay that facilitates the measurement of antithrombin catalyzed inhibition of factor 10A by unfractionated heparin and direct inhibition of factor 10A by low molecular heparin. Wait, let me read again. The anti-factor 10A assay is a functional assay that facilitates the measurement of antithrombin AT catalyzed inhibition of factor 10A. Antithrombin catalyzed inhibition of factor 10A by unfractionated heparin and direct inhibition of factor 10A by low molecular weight heparin. Plasma heparin, unfractionated low molecular heparin levels, and to monitor anticoagulant therapy. Is it though? This very layman. Heparin is a drug that inhibits blood clotting as anticoagulant and is used to treat people who have developed dangerous blood clots, thrombi, or at high risk of developing them. This test indirectly measures the amount of heparin in a person's body, in a person's blood by measuring the inhibition of factor 10A activity. Measuring the inhibition of the factor 10A activity. One of the proteins involved in the blood clot formation, known as heparin, anti-10A activity. Okay, just take it as that lah. But for normal standard unfractionated heparin, APTT is more useful because it also affects other factors lah. 12, 11, 9. Okay, next question. What's the most likely outcome following the diagnosis of minimal change nephropathy in a 10-year-old male? Minimal change is the best prognosis. It's a cause of the pathophysiology of nephrotic syndrome. It's the best prognosis one. So CKD require renal transplantation, probably not. Full recovery, no further episodes, probably not. There's a risk of further episode. Full recovery related recurrent episode. Chronic kidney disease, not requiring renal replacement therapy. Chronic kidney disease require renal replacement therapy within 10 years. Usually it's full recovery lah. And there's a risk of recurrence as well. Yeah. So as 1/3 of patients have infrequent relapses and 1/3 of patients have frequent relapses, a majority, 2/3, will have later recurrent episodes. It is important, however, to stress to patients that generally speaking, the longer term prognosis in minimal change glomerulonephritis is good. Okay. So minimal change disease, some notes. Minimal change disease nearly always presents as nephrotic syndrome, accounting for 75% of all cases of children and 25% adults. The majority of cases are idiopathic, but in around 10 to 20%, a cause is found. Drugs include NSAIDs, rifampicin, Hodgkin's lymphoma, thymoma, infectious mononucleosis, pathophysiology, T cell and cytokine-mediated damage to the glomerular basement membrane causes polyanion loss. What does that mean? Resultant condition of electrostatic charge, increased glomerular permeability to serum albumin. Features: nephrotic syndrome, normal tension, hypertension is rare, highly selective proteinuria, only an intermediate sized protein such as albumin and transferrin leak through the glomerulus. Renal biopsy, normally glomeruli on light microscopy. Normal glomeruli on light microscopy, that's why it's called minimal change. Electron microscopy shows fusion of podocytes and effacement of food processes. Management, majority of cases, 80% are steroid responsive. Cyclophosphamide is the next step for steroid-resistant cases. Prognosis is overall good, although relapse is common. Roughly 1 out of 3 have just one episode, 1 out of 3 have infrequent relapses, and 1 out of 3 have frequent relapses which stop before the output. Okay, let's look at the osmosis video on minimal change disease.
Minimal change disease, sometimes called nil disease, affects the millions of the kidney's glomeruli, which are the specific parts of the kidney where small molecules are first filtered out of the blood and into the urine. Specifically, it's a type of nephrotic syndrome. In fact, the most common nephrotic syndrome seen in children. But what exactly is nephrotic syndrome? Well, usually the glomerulus only lets small molecules, like sodium and water, move from the blood into the kidney nephron, where it eventually makes its way into the urine. But with nephrotic syndromes, the glomeruli are damaged and they become more permeable. So they start letting plasma proteins come across from the blood to the nephron and then into the urine, which causes proteinuria, typically greater than 3.5 grams per day. An important protein in the blood is albumin, and so when it starts leaving the blood, people get hypoalbuminemia, low albumin in the blood. With less protein in the blood, the oncotic pressure falls, which lowers the overall osmotic pressure, which drives water out of the blood vessels and into the tissues, called edema. Finally, it's thought that as a result of either losing albumin or losing some protein or proteins that inhibit the synthesis of lipids, or fat, you get increased levels of lipids in the blood, called hyperlipidemia. Just like the proteins, these lipids can also get into the urine, causing lipiduria. And those are the hallmarks of nephrotic syndrome: proteinuria, hypoalbuminemia, edema, hyperlipidemia, and lipiduria. Okay, so minimal change disease is a type of nephrotic syndrome. Got it. But how exactly do these glomeruli start letting plasma proteins like albumin through? Well, usually in the glomerulus, you've got your endothelial cells lining the capillaries, then the basement membrane, and then the podocytes, which are the cells that have these long tentacle-like projections called foot processes. And this is also why they're called podocytes, since podo refers to the foot. Those foot processes have a negatively charged coat that helps repel negatively charged molecules, like albumin, thereby acting as a charge barrier. With minimal change disease, although not completely known, it's thought that the T cells in the blood release cytokines that specifically damages the foot processes of the podocytes, making them flatten out, a process called effacement. This means that there's less of a charge barrier, right? And albumin is allowed to slip through from the blood into the nephron. Even though albumin goes through, other larger proteins like immunoglobulin aren't allowed through. And so with minimal change disease, there's selective proteinuria. The exact identity and mechanism of these ominous T cell cytokines, though, still remains a mystery. As far as causes of minimal change disease goes, in most cases it's idiopathic, meaning the cause is unknown. Although one interesting clue is that it's associated with Hodgkin's lymphoma, possibly because of the general increase in cytokine production in that disease. For diagnosis, minimal change disease can be kind of tricky. With only light microscopy and H&E stain, you can't see the foot process effacement. and so it seems like there's no change to the glomerulus, hence the names minimal change and nil disease. With electron microscopy, though, you can see effacement of foot processes. Also, immunofluorescence with minimal change disease is usually negative, since the damage is due to cytokines, not immune complex deposition. Treatment of minimal change disease is typically corticosteroid therapy, of which about 90% of children respond very well. Adults also respond well to corticosteroid therapy, but the response is generally slower. In both cases, though, there's a potential for relapse. Alright, so as a short recap, minimal change disease is a nephrotic syndrome thought to be caused by cytokine damage to the foot processes of the podocytes in the glomeruli of the kidney. Thanks for watching. You can
Yep, I have it. Okay, next question. A 57-year-old man presents to his GP due to pain in his right knee. An X-ray shows osteoarthritis. He has no past medical history of note. What is the most suitable treatment option for the management of his pain? Osteoarthritis, pain management. What's the most suitable treatment option for pain management and osteoarthritis? Is it the Onset or paracetamol? I know back pain you can't use paracetamol alone, so according to NICE guidelines. What about osteoarthritis of the knee? You want to try paracetamol first, right? It's the most benign one. Let's see. The answer is oral paracetamol. Osteoarthritis, paracetamol plus topical NSAIDs if knee or hand is the first line. Oral NSAIDs should be used second line in osteoarthritis due to their adverse effect profile. So osteoarthritis management, NICE published guidelines on the management of osteoarthritis in 2014. All patients should be offered help with weight loss, give advice about local muscle strengthening exercise, and general aerobic fitness. Paracetamol and topical NSAIDs are first-line analgesics. Topical NSAIDs are indicated only for OA of the knee or hand. Second-line treatment is oral NSAIDs or COX-2 inhibitors, opioids, capsaicin cream, or intra-articular corticosteroids. A proton pump inhibitor should be co-prescribed with NSAIDs and COX-2 inhibitors. These drugs should be avoided in the patient if the patient takes aspirin. Non-pharmacological treatment options include support and braces, tents, and shock-absorbing insoles or shoes. If conservative methods fail, then refer for consideration of joint replacement. What's the role of glucosamine? Normal constituent of glycosaminoglycans in cartilage and synovial fluid. A systemic review of several double-blind RCT of glucosamine is in new osteoarthritis reported significant short-term symptomatic benefits, including a significant reduced joint space narrowing and improved pain scores. More recent studies have, however, been mixed. The 2008 NICE guidelines suggest it is not recommended. Next question. A 7-year-old boy presents to the GP as he does not seem to be developing in the same way as his classmates. He's now a lot taller than most of his friends and started to develop hair around his genitalia and armpits. On examination, his penis is also large for his age. However, his testes remain prepubertal with a size of 2.4 cm. Which of the following is the most likely cause of this boy's precautious puberty? What's the most common cause? I just recently saw a real case of this, and he had a pineal gland tumor, so I'm not sure about the statistics of that though. Astrocytoma doesn't sound right. Sounds like something in the brain that's not related to hormone production. Sex gonadal stromal tumor. Testotoxicosis sounds rare. Adrenal hyperplasia. And idiopathic precautious puberty. Which one is the most common? Adrenal hyperplasia sounds like a common cause. Let's see. Yep. So small testes in precautious puberty indicate an adrenal cause of the symptoms. In the case of precautious puberty, it is helpful to assess the size of the testicles as to ascertain the cause. As stated below, if the testicles are small, like in this case, it indicates an adrenal cause of the problem. The only option on the list that is an adrenal cause is option 4. And so this is the answer. Why though? Why if the testes are small, it's an adrenal cause? An astrocytoma or any other form of brain tumor would cause central precautious puberty, and this would cause bilateral testicular enlargement. Oh, what's an astrocytoma though? No links here. Astrocytoma is a type of cancer that can occur in the brain or spinal cord. It begins in the cells called astrocytes that support the nerve cells. Some astrocytomas grow very slowly, and others may be aggressive cancers that grow quickly. Astrocytoma is a type of cancer that can form in the brain or spinal cord. Tumors which originate from astrocytes. Glial cells, star-shaped brain cells in the cerebrum called astrocytes. Astrocytes are for supportive function though. A form of glioma, neoplasm of the glial cells, which constitute the supportive tissue of the brain. Why is it involved in hormone production though? Testotoxicosis would cause advanced development in all areas and would be associated with history of sexual aggression during childhood. A sex-cord gonadal stromal tumor will cause unilateral enlargement of the affected testicle. An idiopathic cause of the precautious puberty would cause advanced development in all areas of pubertal development, and thus the testicles would be enlarged. Precautious puberty. Definition: development of secondary sexual characteristics before 8 years in females and 9 years in males, more common in females. Some other terms: telarchy, adrenarchy. Telarchy is the first stage of breast development, adrenarchy is the first stage of pubic hair development. May be classified into gonadotrophy independent, central, or true, due to premature activation of the hypothalamic pituitary gonadal axis, FSH and LH rays, or gonadotropin independent, pseudo or false, due to excess sex hormones, FSH and LH are low. Males uncommon and usually has an organic cause. The testis bilateral enlargement means there's a gonadotropin release from intracranial lesion. Unilateral enlargement is a gonadal tumor. And small testis is an adrenal cause, tumor of adrenal hyperplasia. So females usually idiopathic or familial and follows normal sequence of puberty. Organic causes are rare, associated with rapid onset, neurological symptoms and signs and dissonance. McCune-Albright syndrome. Okay. Okay. Gonadotropin released from intracranial lesion will cause bilateral testis enlargement. How do I know if the testis size is normal? So this is orchidometer. 1 inch, huh? Oh. Childhood 1, 2, 3 is ml, is it? What's the unit here? Volume in ml, okay. So 1 ml, 2 ml, 5 ml, 10 ml, 20 ml, 29 ml. Hmm. Tenor staging. Stat pearls, tenor stages. and it's not a very long article. We can go through the whole thing. So tenor stages. Introduction. Puberty is a time of rapid and complex changes involving overlapping components, hormonal, physical, and cognitive. Tenor staging, also known as sexual maturity rating (SMR), is an objective classification system that providers use to document and track the development and sequence of secondary sex characteristics of children during puberty. It was developed by Marshall and Tanner while conducting a longitudinal study during the 1940s to the 1960s in England. Based on observational data, they developed separate scales for the development of external genitalia, phallus, scrotum, and testis volume in males, breasts in females, and pubic hair in both males and females. The physical changes of puberty require concerted effort from many organs. These changes are initiated by the activation of hypothalamic pituitary gonadal axis. Gonads refer to the ovaries in females and testes in males. The first hormonal change in puberty is the pulsatile release of GnRH triggered by disinhibition of the hypothalamic pituitary gonadal axis. Although the cause of this disinhibition is largely unknown, the subsequent release of GnRH then stimulates the pulsatile release of luteinizing hormone and follicle-stimulating hormone. LH and FSH act on specific gonadal cells to stimulate the release of androgens, estrogens, and the process of gametogenesis. LH stimulates the T cells in the ovary to produce estrogen precursors and the Leydig cells of the testes to produce testosterone. On the other hand, FSH works on the ovarian follicle to convert the T estrogen precursors to estrogen and on the Sertoli cells in the seminiferous tubules of the testes to help create sperm. The complex process leads to increased estrogen and testosterone production that then facilitates the development of breasts and the formation of adult male genitalia. The adrenal glands also contribute to the formation of secondary sexual characteristics, particularly pubarchy, which is the development of pubic and axillary hair. Usually call this adrenarche. Although adrenal maturation often coincides with HPG, hypothalamic pituitary gonadal axis maturation, it is important to note that these processes occur independently of each other and that puberty itself is not the best indicator of pubertal development. Function. The normal onset and sequence of physical maturation vary greatly based on sex, race, and ethnicity, and environmental factors. Tenor stages are utilized in pediatric and adolescent practice to consult patients about the timing of anticipated body changes, perform appropriate medical screenings, and monitor for deviations in normal timing and sequence of physical signs and puberty that may represent physiological problems. Changes that are associated with but not directly measured by tenor staging include bone growth and fusion, body composition and linear growth, and hematocrit values. Tenor staging rather than chronological age should be used in assessing pubertal development. Clinical examples of use include delivering timely anticipatory guidance on menstrual hygiene needs, menarche about 2 years post-telarche or tenor 2 breasts, or targeting scoliosis exams well visits before and during peak height velocity tenor 2 to 3 depending on sex. In females, the normal onset of puberty ranges from 8 to 13 years old, averaging 10 years in white Americans and 8.9 years in African Americans. Puberty in females begins with the development of breast buds under the areola, are also known as telarche, and represents represents entry into tenor stage 2. As puberty progresses, the glandular tissue of the breast increases in size and changes in contour. In females, telarche is followed by in 1 to 1.5 years by the onset of sexual hair, pubic and axillary, known as pubarchy. Menarche, the onset of menses, arrives on average at age 12.5 years, regardless of ethnicity, following telarche on average by 2.5 years, range 0.5 to 3 years. Between tenor stages 2 and 3, breast development females experience peak height velocity. African American females have closer to 3 years between the telarche and menarche, accounting for greater height potential. In males, the onset of puberty ranges from 9 to 14 years of age. The first secondary sexual characteristic visible is gonadarche, when the testicular volume reaches greater than or equal to 4 ml, or long axis greater than or equal to 2.5 cm and enters tenor stage 2. During tenor stage 3, genital development, males undergo peak height velocity, spermachy, A counterpart of menarche in females is the development of sperm in males and typically occurs during genital tenor stage 4. Issues of concern. Pubertal development generally follows a predictable pattern of onset, sequence, and velocity. However, population norms are published to help clinicians determine which adolescents fall outside 2 standard deviations of the mean and require further investigations. Precautious puberty is defined as the onset of tenor 2 secondary sexual characteristics before age 8 years in females or age 9 years in males. If the continued progression of pubertal development occurs soon after, delayed puberty should be considered if females have not reached tenor 2 dilarchy by age of 13 years old, or if males have not reached tenor 2 gonadorrhea by age of 14 years. Primary amenorrhea is defined as a failure to start menses within 3 years of tenor stage 2 dilarchy, or by age 15 years. It is important to note that some males will temporarily develop glandular breast tissue pubertal gynecomastia between genital tenor stage 3 and 4, which may be emotionally troubling but not physically harmful. Abnormalities may be caused by idiopathic conditions, nutritional deficiencies, HPG axis variations, or neoplastic and genetic disorders. Describing these disorders is outside the scope of this article. Clinical significance. Below are the tenor stages described in detail for clinical reference. Tenor stage 1 corresponds to prepubertal form for all 3 sites of development, with progression to tenor stage 5, the final adult form. Breast and genital staging, as well as other physical markers of puberty such as height, velocity, should be relied on more than pubic hair staging. Again, breast and genital staging, as well as other physical markers of puberty such as height, velocity, should be relied on more than pubic hair staging to assess pubertal development because of the independent maturation of the adrenal axis. Pubic hair scale, both males and females. Stage 1, no hair. Stage 2, downy hair. Stage 3, scant terminal hair. Stage 4, terminal hair that fills the entire triangle overlying the pubic region. Stage 5, terminal hair that extends beyond the inguinal crease onto the thigh. Female breast development scale. Stage 1, no glandular breast tissue palpable. Stage 2, breast butt palpable under the areola, first pubertal sign in females. Stage 3, breast tissue palpable outside areola, no areola development. Stage 4, areola elevated above the contour of the breast, forming a double scoop appearance. And stage 5, areola mound recedes into single breast contour with areolar hyperpigmentation, papilla development, and nipple protrusion. Male external genitalia scale. Stage 1, testicular volume less than 4 ml or long axis less than 2.5 cm. Then stage 2, 4 ml to 8 ml or 2.5 to 3.3 cm long. We're talking about the testicle or the penis. We're talking about a penis? No, testicles, because you're measuring in ml and then you bracket in cm. So ml is the main one, 4 to 8 ml. First pubertal sign in males. Stage 3, 9 to 12 ml or 3.4 to 4 cm long. Stage 4, 15 to 20 ml, 4.1 to 4.5 cm long. Stage 5, more than 20 ml or more than 4.5 cm long. We're measuring the length of testis. Enhancing healthcare team outcomes. An interprofessional team of clinicians and nurses should provide the screening evaluation of pediatric patients. All healthcare workers, including nurses, nurse practitioners, physicians, assistants, and physicians who evaluate pediatric patients, should know the tenor stages. This allows them to know if sexual development is normal or abnormal. The earlier the referral to the appropriate specialist, the better the outcomes. Okay, so pubic hair, scant terminal hair, stage 3, downy hair, stage 2. Stage 4 is the triangle, and stage 5 extend beyond inguinal crease. For breasts, no glandular tissue palpable, stage 1. Breast butt palpable under areola, first pubertal sign in females. Breast tissue palpable outside area, no areola development. Areola elevated, stage 4. And then areola mound recedes into single breast contour, stage 5. Stage 1, male external genitalia is testicular, the volume of less than 4 ml. Long axis less than 2.5 cm. Stage 2, 2.5 to 3.3 cm long. How can testis be more than 4.5 cm long? Though, let me look at the rule. 4.5 cm. 1 cm, 2 cm, 3 cm, 4, 4.5. Cannot be a testis this long. Doesn't sound right. Oh well. Left testis length 16 cm. What the heck is going on? Huh? Huh? How long is this? Is this cm or what? Mm. Oh, very long, huh? Okay lah. I underestimated the size of testes. Stage 1 is less than 2.5 cm. It's very short. 3 cm is already 10 at stage 2. 4 cm, 3 or 4. Okay. Next question. A 57-year-old male presents in emergency department with 12-hour history of sudden onset left-sided hearing loss. His hearing loss is accompanied by new onset tinnitus. He denies any trauma or exposure to loud sounds and feels well in himself. He denies any weight loss, night sweats, or fever. He has no past medical history or surgical history. He does not take any medication regularly apart from over-the-counter vitamin D supplement. You perform a full cranial nerve examination and note the below findings for assessment of cranial nerve 8, vestibular cochlear nerve. Weber's test, louder in right ear. Rinse test, positive. Positive is normal lah. Right. Louder in the right ear. This is the left sensory neural hearing loss. Following the urgent referral to ENT was the most appropriate next step in management. Weber's test, louder in here. Means test positive. What does positive mean? Positive means air greater than bone or bone greater than air. Huh? Is positive the normal one or the pathological one? Eesh, need to remember this lah. Means test positive means air better than bone. I assume like that lah. Air better than bone means test positive. So that means it is a sensory neural hearing loss of the left ear. And let's look at the clinical picture. 12-hour history, sudden onset left-sided hearing loss. New onset tinnitus. No trauma, loud sounds. Weight loss, no night sweats, no fever. Acute 12-hour history. 12-hour history. Hearing loss. Has tinnitus. It's only hearing loss, does not have balance loss. 57-year-old. Sensory neural hearing loss. I don't know what's going on here. Vestibular neuritis? I'll assume it's vestibular neuritis because of the 12-hour history. So what do you do for vestibular neuritis? What's Synarizine? Why you wanna give dexamethasone? Why you wanna give prednisone? What is Synarizine? Why you wanna give prednisone? What is going on here? I have no idea what is going on here. If it's vestibular neuritis, usually it's just conservative management. So it's probably not vestibular neuritis here. It's 57-year-old. Maybe vestibular neuritis, you want to reduce inflammation, you can give oral prednisolone. Why high dose? Why low dose? So the answer is high dose oral prednisone. Following a referral to ENT, patient with sudden onset sensory neural hearing loss are treated with high dose oral corticosteroids. This figure shows a patient with sudden onset sensory neural hearing loss as indicated by the results of the Rins and Weber's test. Please see below. So let me see. Positives. Yes. Patients should be able to hear the sound tuning for adjacent to their ear persists for approximately twice as long as the sound over the mastoid process. It's considered positive test. Positive is normal, it means test. Okay. This figure shows a patient with sudden onset sensory neural hearing loss as indicated by the results of the Rins and Weber's test. Please see below. The majority of sudden onset sensory neural hearing loss is idiopathic in nature. However, it can be attributed to autoimmune conditions, as for example, Behçet's disease or SLE, infectious causes, for example, bacterial meningitis, mumps, Lyme's disease, metabolic causes, for example, diabetes, hypothyroidism, or neoplasm. The management of sudden onset sensory neural hearing loss is urgent referral to ENT, high-dose oral corticosteroids, and investigation for causes. There is emerging evidence to support a trial of intratympanic dexamethasone as an alternative to high-dose oral prednisolone. However, this has not formed standard practice protocol yet. In idiopathic causes, 45 to 65% of patients will regain their previous hearing threshold even without any therapy. However, age more than 60 years or less than 15 years is associated with a poorer outcome. vestibulocochlear nerve assessment. You got Weber's test and Rain's test. I know about this. Okay, normal. Air better than bone. Normal test is term positive. Since sudden onset sensory neural hearing loss. When a patient presents sudden onset hearing loss, it is important to examine them carefully to differentiate between conductive and sensory neural hearing loss. Sudden onset sensory neural hearing loss requires urgent referral to ENT. Why? The majority of sensory neural hearing loss causes are idiopathic. So because I think they wanna make sure it's not a stroke, ischemia, brain or something. 45 to 65% will regain previous hearing thresholds if it's idiopathic. An MRI scan is usually performed to exclude vestibular schwannoma. Vestibular schwannoma. Okay, high-dose oral corticosteroids are used by ENT in all cases of sensory neural hearing loss. No, not giving me any reason. I'll just assume that they will assume it's some sort of inflammation and just give spam steroid on you. A few reasons, like I think, because even if it is intracranial lesion, right, giving steroids will sort of reduce edema, just relieve the pressure on the nerves temporarily as well. If it's vestibular neuritis, there will be inflammation. Prednisolone is like corticosteroids just suppresses the immune system, you know, so suppresses the inflammation as well. Right, that's 8 questions. Let's do 10 and then we'll take a rest. A 78-year-old patient comes to the hospital for elective total hip replacement. She receives deltaparin post-operatively for thromboprophylaxis. 8 days post-operatively, she goes on to develop shortness of breath and pleuritic chest pain, and her full blood counts results are shown below. She's diagnosed with pulmonary embolism. Sounds like heparin-induced thrombocytopenia, right? HB is 124, which is low. Platelets, wait, is she female or male? She is a female, so it's a normal. HB is normal. Platelets is low. So which is how to say, in line with HIT, heparin-induced thrombocytopenia. White blood cells is normal. What is the most likely cause of a pulmonary embolism? HIT. She's on deltaparin, which is a low molecular weight heparin. Although low molecular weight heparins have a lower risk of HIT compared to unfractionated heparin, that is still at risk. And what happens is there are antibodies formed against the heparin PF4 complex, which causes activation of your platelets, and then it causes a DIC-like picture, so causes your platelets to aggregate. You have you consume all your platelets, but then it's a prothrombotic instead of antithrombotic effect. So not even gonna look at the rest. The answer is HIT. We went through this already. Concurrent use of which one of the following would make combined oral contraceptive pill less effective? COCP. So any enzyme induces which will cause COCP to be less effective. Carbamazepine is an inducer. Remember CREP GPS? These are inducers. CREP. If the GPS is CREP, it induces your rage. It's by the USMLE. So C stands for carbamazepine, A stands for azithromycin. CR, carbamazepine, rifampicin, azithromycin. I think phenobarbital, phenytoin, griselfulvin, F stand GP, phenobarbital, phenytoin. S stands for sulfonamide, I think. Let's look for the mnemonic. This one. BS, crap GPS, barbiturate syndrome what? Carbamazepine, rifampicin, alcohol. Alcohol, not azithromycin. Alcohol. Phenytoin, glycosylphosphine, phenobarbital, sulfonylureas, not sulfonamides. Sulfonamides are actually inhibitors. Okay. So sulfonylureas. Sulfonylureas include, what is metformin? Metformin is a biguanide, right? Sulfonylurea is a example. It's the glycoside. Sulfonylurea, I think. Sulfonamide. Sulfonylurea. Wait, sulfonamide and sulfonylurea, same thing, is it? Group sulfonamide, and then it is sulfonylurea. Wow, so confusing. Because over here it says sulfonamide is inhibitor, sulfonylurea is inducer. Very confusing. Anyway, these kind of questions. Not useful in. I mean, okay lah. You need to know for SBA. Okay, last question. Concurrent use of which one of the following would make combined oral contraceptive less effective? Oh, I haven't answered this. It's the same thing, right? Carbamazepine. Okay. Inducer. This is 30 US ml. They changed their channel name to Dirty Medicine because I guess they're not just focusing on USMLE anymore. Let's look.
P450 enzymes are actually incredibly high yield for USMLE and complex. I want to start this video by talking about the different P450 inducers and inhibitors. I'll list all the drugs, explain the pathophysiology of what happens to affect drug metabolism, and then we'll wrap up the video by talking about the specific subtypes of the P450 receptors, which has become a very annoying topic to memorize. Of course, I'll give you my mnemonics along the way as we go through the normal physiology, and we'll wrap up by doing a summary of everything that you need to know. So when we talk about P450 enzymes, it's probably best to start by talking about certain drugs that act on the enzymes. Now, certain drugs can either be inducers of P450 or they can be inhibitors of P450. So we're not talking about the enzyme itself, right? I'm not saying that the P450 enzyme is the inducer or is the inhibitor. What I'm actually saying is that certain drugs induce P450 or certain drugs inhibit P450. So let's start by listing out the drugs that act as inducers of P450 enzymes. Those drugs are seen here: carbamazepine, rifampin, alcohol, phenytoin, glycosylphosphine, phenobarbital, and sulfonylurea. So all of these drugs are P450 enzyme inducers. So what does that actually mean? Well, let's talk about the normal physiology and pharmacology here. So normally you have this drug, and the drug over time interacts with a P450 enzyme. So under normal circumstances, that over time you take the drug and eventually the drug needs to be broken down. So when the drug is reaching its half-life and starting to be metabolized, that P450 enzyme will work its way toward the drug, will latch onto the drug, and then will basically destroy the drug by metabolizing it. And this is all a normal process. Drugs have to be eliminated and metabolized by our body, and that's done by enzymes. So that drug disappears, and you're left with the P450 enzyme, which can then go and find other molecules in the body to keep on breaking down. So that is the P450 system. Now let's go back to this slide. What happens when you put a inducer of P450 into the equation? So the inducer is shown here in green. So this could be any one of those drugs that we just listed, right? Carbamazepine, rifampin, alcohol, phenytoin, glycosylphosphine, phenobarbital, or sulfonylureas.
It's phenobarbital. The barbiturate. It's a long-acting barbiturate.
Any one of those drugs, if you take them, will have an effect on P450's ability to metabolize other drugs. So what this does is it speeds up this process because it's an inducer of P450. So when P450 isn't around to normally metabolize these drugs, but you take an inducer of P450, so you take one of those other drugs that I listed on the previous slide, P450 shows up faster and accelerates toward the drug, metabolizes the drug, and destroys the drug. So what I'm saying here is that a P450 enzyme actually induces P452, or excuse me, a P450 inducer induces P450, as the name suggests. So usually the enzyme is not going to metabolize the drug until later on in the day, let's say. But when you take an inducer, you make P450 show up faster, metabolize the drug faster, and get rid of some other drug faster. So inducers of P450, in a nutshell here, they increase drug metabolism. So you have to be careful because if you're taking some other medication and all of a sudden you start taking, in addition to that other medication, you start taking something like phenytoin. Phenytoin induces P450, which breaks down that other medication that you normally take, and therefore that other medication doesn't do its job because it's getting broken down early because you're inducing P450 to break down that other drug. So that's how the P450 inducers work. Now let's switch gears and talk about the P450 inhibitors. So I listed them out here for you: valproic acid, aka valproate, ketoconazole, isoniazid, sulfonamides, chloramphenicol, amiodarone, erythromycin, and I want to say with erythromycin, it's really all of the macrolides with the exception of azithromycin, quinidine, and grapefruit juice. So let's talk about the pharmacology and the physiology of the inhibitors. So again, normally you have some other drug in your body that you normally take. Over time, it needs to get broken down. It'll go through its normal half-life, it'll get metabolized. The P450 enzyme will associate with the drug, it will metabolize the drug, and the drug will be broken down. But what happens when you introduce a second drug, aka a P450 inducer? So shown here in red is our P450 inhibitor. Excuse me, I said inducer, but I meant to say inhibitor. So the P450 inhibitor, which is any one of those drugs that I just listed on the previous slide, inhibits P450. So normally P450 wants to go and metabolize the drug, but a P450 inhibitor will inhibit the P450 enzyme. So it literally sits right on top of the enzyme and prevents it from doing its job. That enzyme goes away, and instead of normally metabolizing the other drug shown in blue on this slide, that other drug shown in blue will actually have a super therapeutic effect because the P450 inhibitor is inhibiting the enzyme that normally breaks down the other drug. So this will decrease drug metabolism, and basically this can cause toxicity or buildup of the drug that needs to be normally broken down. So P450 inhibitors cause drug toxicity by building up drug effects because they decrease drug metabolism, and P450 inducers do not cause drug toxicity, but they cause a subtherapeutic effect because they increase drug metabolism, and therefore there's no drug around to actually carry out its effect. So those are the differences, the big picture differences between the inducers and the inhibitors. What's really important for you when you're taking USMLE and Comlex is to know which drugs are inducers and which drugs are inhibitors. Now, of course, this is a very long lesson. There's no easy way to memorize this. Oh, but there is. I'm going to give you my mnemonic to remember the P450 inducers. So if you look at the first letter here, I bolded them and put them in red. The mnemonic is crap GPS induces my rage. So I don't know if you guys remember before iPhones had the GPS on them, everybody used to use like their Garmin or their TomTom. They used the GPS, but if you were ever driving with your GPS and it couldn't calculate the map fast enough or was just buffering, that was the most rage-inducing thing of my life. I fucking hated that. So crap GPS, C-R-A-P GPS, corresponds to the letters of the drugs that are inducers. So they induce my rage. If you can look at this list and know what the inducers are, then by process of elimination, you'll know what the inhibitors are. So I never, ever memorized the inhibitors, but I just memorized the inducers using my mnemonic. And then on test day, if I got some question where it was very clear they were asking me about either an inhibitor or an inducer, if it wasn't one of the crap GPS drugs, then I knew it was an inhibitor, and therefore I knew it was inhibiting P450, and I would work that out in my head to figure out what the answer was. But you literally cannot go wrong if you know this mnemonic. So crap GPS induces my rage. Carbamazepine, rifampin, alcohol, phenytoin, glycopholin, phenobarb, and sulfonylureas, they all induce P450, which means P450 shows up and breaks down the other drugs faster, so the other drugs don't have as big of an effect. That's all of the induction, and then inhibition of P450 is just the complete opposite, and you'll know those drugs by process of elimination. So what I would say is take some time to just stare at this slide and know what the inhibitors are. So know that ketoconazole and valproate and sulfonamides and chloramphenicol are either inducers or inhibitors, and then if you get a question in your head, use the crap GPS induces my rage mnemonic to figure out which one it is, and just use process of elimination. I've done this my whole life in medicine, and it's never been a problem for me. So
next question. Okay lah. Let's end it for now. 10 questions done already. I'll see you in the next one. Yeah, it's been 1 hour.